Before we begin, I'd like to ask unanimous consent for fellow committee member Congressman Sablon from the Northern Mariana Islands to sit on the dais and participate in today's proceedings. Without objection, so ordered. Thank you. With that, good afternoon, and thank you all for joining us today to discuss the Department of Veterans Affairs fiscal year 2018 budget submission, particularly as it pertains to medical and mental health care, community care, medical and prosthetic research, construction and infrastructure, and veteran homelessness. There's certainly no shortage of topics to address this afternoon, so I will keep my opening comments short in hopes of devoting most of our time to questions. However, there are 3 points I want to discuss before hearing from Ranking Member Brownley and our witnesses. First, the President's budget request includes $186.5 billion in budget authority for VA in fiscal year 2018, an increase of $6.4 billion over fiscal year 2017. Some have alleged that the increased funding for the Veterans Health Administration in this budget goes primarily to community care programs like Choice, rather than traditional in-house VA programs, which some claim is a dangerous step toward privatization. This is not the case, and privatization is certainly not the goal. As the Secretary clarified in testimony before the Senate just yesterday, the increase provided to medical services in this budget is 3 times as large as the increase provided to community care. Second, the elephant in the room this afternoon is the unexpected shortfall in the Choice Fund that the Secretary announced last week. In a letter sent to the committee on Friday evening, Secretary Shulkin wrote that higher than expected utilization of the Choice program this year has resulted in an acceleration of funds being expended from the Veterans Choice Fund and without significant changes to current Choice processes. The Choice Fund is expected to run dry by August 15th. There are a number of questions remaining today about the extent of the shortfall, the resources and actions the Secretary needs and when to address it, and the consequences of inaction for veteran patients who, more than ever before, are relying on Choice to get the care that they need. Dr. Allais, I'm hoping that you will be able to provide some clarity this afternoon on all those fronts. Finally, as the Choice Fund shortfall clearly illustrates, we have challenges ahead, problems that we cannot solve without the help of our veteran service organization partners. I'm grateful to Disabled American Veterans, the Paralyzed Veterans of America, the Veterans of Foreign Wars, and the American Legion for agreeing to testify this afternoon. We share a mutual sacred goal, meeting the health care needs of veteran patients, and we're relying on you to come to the table with actionable solutions for how we can move forward together, given the fiscal realities that we all know exist. We can't hide from them. I'm grateful in advance for your candor and your cooperation, and I'm very much looking forward to today's discussion. And with that, I will now yield to Ranking Member Brownley for any opening statement that she may have.
Thank you, Mr. Chairman, and thank you, Undersecretary, for being with us here today. I look forward to hearing from you on how this budget request will meet the health care needs of our nation's veterans. I'm also looking forward to testimony from the VSOs on whether or not this budget request meets the needs of their millions of veteran members. Dr. Allais, as Acting Undersecretary of Health, you have taken on more in the last few months of your tenure than many permanent undersecretaries attempt in their entire period of service. Over the last few months, VHA has committed to the acquisition of a commercial electronic health record system, the extension of the Choice program to utilize all of the funds Congress provided in 2014, the consolidation of capital assets, the establishment of a White House hotline, and VA's decision to drop the appeal of the Staub case. And while these commitments and decisions seem to be necessary on their face, I question whether VHA has been realistic in their request for the funds to support these costly commitments. I hope today that you and the VSOs here can help my colleagues and myself understand how VHA plans to successfully execute these commitments while ensuring that quality and access to VHA care is improved and not sacrificed. Because members of this committee on both sides of the aisle want you to succeed and build the 21st century high-performing VHA our veterans deserve. I'm especially interested in hearing more today about services and programs to improve women veterans' health care. This cannot fall by the wayside. By 2035, the population of women veterans is expected to swell to 35% of the total veteran population. VHA must be prepared to meet these expanding population's needs. Women veterans deserve to receive care from professional providers in comfortable settings and an easily accessible manner. We need to keep working to break down barriers that may be preventing women veterans from receiving VA care, and I look forward to hearing from you, Doctor, and the VSOs about how we can do it better. I'm also looking forward to hearing more about other programs, including the Caregiver Program, the future of the VA's care in the community accounts, medical research, and services to address mental health and veteran suicide. While I'm glad to see a general increase in funding at VHA, we also want to hear more about some of the cuts and spending decisions included within the budget and how these could impact the care we provide to our veterans. Dr. Oleg, yesterday we had an opportunity to meet and talk about some areas of concern I have regarding the services in my district and across the country, and I appreciate the dialogue that we have had on these issues. I hope today we can continue that open dialogue and work together and with the VSOs to determine what level of funding is necessary to ensure the VHA can accomplish its full mission. Thank you, Mr. Chairman, and I yield back the balance of my time.
Thank you. Joining us this morning on our first and only panel is Joy Elam, the National Legislative Director for the Disabled American Veterans, Carl Blake, the Associate Executive Director for Government Relations for the Paralyzed Veterans of America, Carlos Fuentes, the Director of the National Legislative Service for the Veterans of Foreign Wars in the United States, Matthew Schuman, the Director of the Legislative Division for the American Legion, and Dr. Poonam Alay, the Acting Undersecretary for Health for the Veterans Health Administration of the Department of Veterans Affairs, who is accompanied by Mark Yao, the Chief Financial Officer for the Veterans Health Administration. I want to thank you all for being here this afternoon. Ms. Elam, we will begin with you. You're now recognized for 5 minutes.
Thank you, Mr. Chairman and members of the subcommittee. On behalf of DAV and as one of the co-authors of the independent budget, I'm pleased to present our views on the budgetary needs for a few of VA's most critical health care programs. While the IB appreciates the increases recommended for VA in the President's budget, we are concerned they are not sufficient for VA to meet significant increased demand for care and its goals of providing timely, high-quality care to veterans both in the VA and in the community. We applaud the Secretary Shulkin for his leadership and efforts to restore veterans' trust in VA and to improve their access to care and benefits, as well as his focus on reforming inefficient business practices and modernizing the department. We note the Secretary has also set forth a number of other priorities: building a high-performing healthcare network, addressing capital infrastructure needs, replacement of VA's electronic health record and critical IT systems, expanding mental health services to veterans with other than honorable discharges, and a campaign to eliminate suicide in the veteran population. While we support all of these reforms, we want there to be an honest assessment and discussion about what the real costs are for accomplishing all of these important goals. Additionally, we ask that you reject the proposals included in the President's budget that would eliminate individual unemployability benefits and round down veterans' disability compensation cost of living adjustments for millions of service-disabled veterans. Another important issue to veterans is timely access to VA mental health services. Veterans with serious mental health illness, post-deployment mental health challenges, including PTSD associated with combat or sexual trauma, are best served by VA's highly skilled mental health providers and its comprehensive mental health care model. These services are also critical to VA's suicide prevention efforts. We also note the Secretary proposed opening access to mental health care for veterans in crisis who have received a less than honorable discharge. While we support this initiative, we are concerned that no additional resources have been put forth in the budget to address a potential increase in workload, hire additional providers, or expand clinical space if necessary. We also want to ensure appropriate funding is available to improve VA care and services for women veterans. The IB recommends an additional $110 million for Women's Health Program to meet increased demand for services, including coverage of gender-specific care, hiring and training of women's health providers, expansion of child care pilot and days of care for newborns, as well as renovating VA's facilities to resolve identified privacy and safety deficiencies. Additional funding is also essential to continue research on the health impacts of wartime service on women veterans and to better address the high rates of homelessness, suicide, and unique transition challenges among this population. These services are especially critical for women veterans with service-connected disabilities, women veterans with wartime service, and veterans who have experienced sexual trauma. Finally, we ask the subcommittee to eliminate the inequity in the current caregiver law this year, which limits essential services and supports to family caregivers of post-9/11 veterans. The limitation left thousands of seriously disabled veterans' families without the level of caregiver support and services they desperately need and deserve. It's time now to recognize the selfless service and dedication of all our caregivers by including resources in the fiscal year 2018 budget to finally resolve this inequity. In closing, the new administration has pledged full support for our nation's veterans and a reformed VA. Secretary Shulkin is committed to carry out that promise by creating a system that is worthy of their service and sacrifices. As VA moves forward to rebuild trust with veterans, make needed reforms, and carry out modernization plans to strengthen and improve veterans' health care, we must ensure VA has the resources and support needed to be successful. Mr. Chairman, that completes my statement, and I'm prepared to answer any questions you may have. Thank you.
Thank you. Mr. Blake, you're now recognized for 5 minutes.
Chairman Winstrup, Ranking Member Brownlee, Chairman Rowe, and members of the subcommittee, on behalf of Paralyzed Veterans of America, our co-authors in the independent budget, VFW and DAV, I'd like to thank you for the opportunity to testify today. I think I'd like to begin by applauding the VA and the Secretary for a number of recent decisions that he's made. With regards to the IU proposal and the need to use that money to fund the choice program, he has said they will drop the IU proposal as a means to fund it. That's the right decision. The Staub ruling, the decision to drop the appeal so that veterans can now get reimbursed for emergency care sought in the community. The decision in that case, that's the right decision. The decision with regards to finally coming to a linkable, interoperable solution in EHR with the Department of Defense, that looks like it's the right solution. The decision as it relates to other than honorable discharges, it will serve veterans that need to be served, that's the right decision. The caregiver expansion, we all in this room know what the right decision is. It has yet to be made, but it needs to be made. But now let's think about the financial impact of those right decisions. The IU proposal alone leaves $3.2 billion that must be addressed. You cannot be unequivocal about that. $3.2 billion that now has to be addressed in some fashion. The Staub ruling, that's $2 billion in outstanding obligations from the previous 2 years, plus what will likely be an average of $1 billion going forward under that requirement. We don't even know yet what the EHR costs will be in the long term. There are estimates, but they vary. Same with the other non-honorable discharge. We know that the caregiver expansion will cost significant money. That doesn't mean that it's not the right thing to do. I've heard in the last week or two a lot of discussion about, well, VA has its collections money available, has its carryover funds available, it needs transfer authority, all of these ways that they can presumably get to fixing these problems. But let's be reminded, the IU and the Staub rulings alone are $5 billion. I don't work in the VA, but I doubt that there's $5 billion laying around at central office or in the VISNs available to fill those holes. The fact is the VA has not been fully forthcoming with what it needs for these purposes. And to keep saying, well, we have collections money available, we have carryover money available, just give us the transfer authority, we can make this work. That's nonsense. We have grown weary of that nonsense. I'll grant you that collections money is available, but it's already planned for some purpose in VA. It's built into its VA's budget baseline. If you take that money and fill the choice hole, what did you take it away from? There are crosswalks that might demonstrate where they're taking from, but you better be able to justify where you're taking that money from. Carryovers, I'll grant you, the VA ends up with significant amount of money available each year in carryovers. My understanding is some of what they have available is fenced for the hepatitis decision, and with some flexibility they can repurpose that because they came in under cost to meet the hepatitis need. But we often get asked the question, why the hell does the VA still have carryover money at the end of the year, particularly when it's hundreds of millions of dollars? What are they spending their money on? Or better yet, what are they not spending their money on? I understand that they can't spend more than they're given. I fully understand that. But when the VA has hundreds of millions of dollars left over in carryover year, it begs a lot of questions about how they're being efficient with their resources. The idea that you can have, they just need the transfer authority to move money around. The Secretary has really sort of harped on this, is give us the ability to transfer money out of the medical community care account to fill in the hole on choice. Fine. If you want to do that, fine. But I ask you, what happens to the veterans being served in that medical community care account space currently? How are you going to address their needs? Or if you take it from somewhere else? A perfect snapshot of this transfer authority issue is the NRM piece of medical facilities. For years, the VA requested approximately $500 million for NRM. I can tell you, and the VA knows, they actually spend about $1.3 to $1.4 billion every year. They actually spend that money. Where is that money coming from? What are they borrowing from to pay for that bill? What Peter are they robbing to pay Paul? We are tired of this. The VSOs, the veterans we serve, the veterans that seek care from the VA are tired of this. It's time to just do it right. Tell us what you need. Let Congress act upon it. The MilCon VA Appropriations and the Full Appropriations Committee just last week approved their bill to fund the VA. It's less than the administration's request. Does that sound like it's a good idea? Because I certainly don't think so. Mr. Chairman, I'd like to thank you again for the opportunity to testify. I'd be happy to answer any questions you or the members may have.
Thank you, Mr. Blake. Mr. Fuentes, you're now recognized for 5 minutes.
Chairman Wenstrup, Ranking Member Brownlee, and members of the subcommittee. On behalf of the men and women of the VFW and our auxiliary, I'd like to thank you for the opportunity to present our views on VA's budget requests. The VFW is glad the administration has proposed a 6% increase in VA's discretionary budget. We also strongly support the department's focus on increased access to high-quality health care for our nation's veterans, combating veteran suicide, including partnerships with organizations like the VFW to leverage our footprints in communities around the country and the world in an effort to eliminate the stigma associated with seeking mental health care. Ensuring VA is ready and able to care for women veterans, who are the fastest growing cohort of the veterans population, and the continued commitment to end veteran homelessness. However, I would like to make it clear that the VFW strongly opposes efforts to claw back benefits from our most severely disabled veterans. In the past 2 weeks, more than 40,000 letters and emails from VFW members and supporters have been sent to members of Congress opposing the administration's proposal to revoke individual unemployability benefits for veterans who are unable to work because of their service-connected disabilities. The VFW opposes the IU and the COLA round-down proposals in the department's budget request, and we're glad to see Secretary Shulkin has agreed to look for other ways to fund the CHOICE program. The continued failure by Congress to eliminate sequestration has forced the administration to propose cuts to veterans programs in order to expand the CHOICE program under mandatory spending, instead of including the program in discretionary spending. Sequestration and Budget Control Act spending caps limit our nation's ability to provide service members, veterans, and their families the care and benefits they have earned. The VFW calls on this subcommittee to join our campaign to end sequestration and do away with arbitrary and outdated budget caps. For more than a decade, the IBVSOs have warned Congress and VA that perpetual underfunding has allowed VA's infrastructure to erode while its capacity has swelled from 81% in 2004 to as high as 120% in 2012. We continue to believe that this need for space and chronic underfunding of VA's major construction projects could force VA to ration care. VA's budget request says that improving the conditions of VA facilities through major construction projects accounts for the largest resource need to keep pace with the growing demand of VA outpatient care. Yet the administration's request only funds one VHA major construction project. The IBVSOs believe that VA has requested an adequate amount for major medical leases. However, Congress must find a way to quickly authorize leasing projects. There are now 27 major medical leases awaiting congressional approval. Delays in authorization of these leases have a direct impact on VA's ability to provide timely care to veterans. The VFW urges the committee to swiftly pass legislation that would streamline the authorization process for VA's major medical leases. Mr. Chairman, this concludes my remarks. Happy to answer questions that you or the members of the subcommittee may have.
Thank you, Mr. Fuentes. Mr. Schuman, you're now recognized for 5 minutes.
Earlier this week, a fellow veteran called the American Legion for help. She was seeking medical care from the VA, and mammograms specifically, but the VA employee told her that the request was denied because funds for the choice program were depleted. Fortunately, the VA employee was wrong. Our staff contacted Dr. Bala Yahia, the Deputy Undersecretary for Health Community Care at the VA, who determined the funds were available so this veteran could receive the medical diagnostics she deserved. The bad news is the choice program seems to confuse even VA staff. The good news is the American Legion and Dr. Yahia were able to ensure the veteran got the care she needed. Chairman Winstrip, Ranking Member Brownlee, Chairman Rowe, and members of the subcommittee, on behalf of Charles E. Schmidt, the National Commander for the largest veteran organization in the United States, representing more than 2.2 million members, we welcome this opportunity to comment on the President's proposed budget. The American Legion has reviewed the President's budget request, and while we fully support the administration's proposal to increase discretionary budget for the VA by $4.3 billion, we would like to draw this committee's attention to several components of this request that only Congress can address. In 2014, President Obama signed the CHOICE Act. The American Legion supported this program as a temporary emergency measure, provided it had a sunset date. Through increased emphasis on eradicating all hidden wait lists and ensuring that all veterans asking for VA medical appointments were seen within 30 days or less, VA quickly exhausted their community care accounts while CHOICE funding remained largely untouched. Because of the way CHOICE was funded, VA couldn't adjust the funding between their traditional contracting accounts. This created an unbalanced community care program. Then Secretary McDonald mandated all appointments be pushed into the CHOICE program to spend the money. This decision caused an artificial dependence on the CHOICE program while preserving VA's more established community care program accounts. The American Legion calls on the President and this Congress to support VA medical infrastructure by reallocating the funding proposed in the 2018 presidential budget toward current community care programs and allowing CHOICE to expire. Shifting from CHOICE to mental health, about 1/3 of returning service members report mental health symptoms and suffer from major depression or post-traumatic stress disorder. 16 years of continuous conflict in Iraq, Afghanistan, and elsewhere has increased the demand for mental health services at VA. Unfortunately, there is a national shortage of mental health care providers, and this shortage is projected to grow over the next decade. Simply stated, there is an urgent need to respond and assist veterans in a timely and responsible manner, and the American Legion calls on the President and this Congress to increase funding to eradicate mental health staffing shortages. Focusing on medical research and IT, I think we can all agree that medical research is essential to improving the quality of care for veterans. The American Legion noticed that in the President's budget, $18 million had been stripped out of the IT appropriation for all VA research. We are very concerned about the long-term impacts of cutting research projects like the Million Veteran Program. Few people know that the VA has built the world's largest and most robust genomics database where medical investigators are currently studying Gulf War illness, PTSD, bipolar illness, and more. The VA's medical research helps to advance VA healthcare and ensure the VA delivers world-class, innovative services to veterans. A significant cut like this will negatively impact veterans. Secretary Shulkin, in a speech made at the White House, stated he planned some drastic changes to VA IT. In fact, he mentioned this may be the only area in which he asked Congress for more funds. As previously stated, the American Legion is very concerned about the long-term impacts of $18 million cut to the VA IT architecture, and we call on the President and this Congress to fully fund medical research and modernization. Lastly, I will quickly address some ideas to pay for the increased budget at VA. The American Legion aggressively opposes cannibalizing existing benefits earned by veterans to support benefits for other veterans. Without question, the proposal to eliminate the individual unemployability benefit is one of the worst ideas the American Legion has heard in years. We've received many calls and emails from our members expressing alarm. I personally spoke to a veteran who began crying as he explained to me that he would literally lose his home if his IU benefit was cut. Additionally, the President's proposed budget would also round down to the nearest dollar the annual cost of living adjustment. Like IU, this is a bad idea, and the American Legion opposes this. The simple reality is we should not be asking veterans to pay for their own earned benefits. Chairman Winstrup, Ranking Member Brownlee, Chairman Rowe, and members of this committee, it is my honor and duty to share the American Legion's analysis of the President's budget with you, and I very much look forward to answering any questions you may have. Thank you.
Thank you. Dr. Lay, you're now recognized for 5 minutes.
Good afternoon, Chairman Winstrup, Ranking Member Brownlee, and members of the subcommittee. Thank you for the opportunity to appear before you to discuss the Veterans Health Administration's FY 2018 budget submission and FY 2019 medical care advance appropriation requests. I'm accompanied today by Mark Yao, our CFO at VHA. By way of introduction, I have served as a physician and a healthcare executive in both the private sector and the government sector for over 25 years. I've also served as a frontline physician at the VA Medical Center in New Jersey for over a decade. Then, as now, I have continued to learn a great deal from my patients. My respect for these selfless men and women only grows deeper each day. I'm grateful to be here in support of veterans and VHA employees. I believe that it is my personal mission, responsibility, and privilege to support them in every way that I can. Because of their sacrifices and service, I'm committed to making sure veterans receive the very best care anywhere. The 2018 budget request will allow VHA to continue on the path begun by then Undersecretary Shulkin towards improving the timeliness and quality of care. This also fulfills the administration's strong commitment to all of our nation's veterans by providing the resources necessary to support those who have earned this care through sacrifice and service to our country. This budget is not designed to privatize the VA, but rather to get the veterans the best care when and where they need it. Our goal is to make VA strong. We are committed to making VA services best in class. Suicide prevention is our most important clinical priority at the VA, and it is critical that we make suicide prevention everybody's priority. We have thousands of healthcare professionals helping save lives of veterans every day. Our Veterans Crisis Line continues to do amazing work. Since its inception, the VCL has answered over 2.9 million calls, dispatched priority services and rescues to over 77,000 veterans, and referred 470,000 veterans to local VA suicide prevention coordinators. We have also launched ReachVet, a program that analyzes veteran data and identifies those veterans at increased risk for suicide and hospitalization. We are also training all VA staff through Operation SAVE, teaching everyone to recognize the danger signs of suicide and the steps to be taken to prevent this tragic and unnecessary death. There are many examples of VA employees that have helped prevent a veteran's suicide. For example, a VA employee saw a veteran on a ledge at the top of a VA parking garage. He looked depressed. This employee sent one of her colleagues to get the police while she calmly talked with him until they arrived and saved his life. This is just one story. We will continue to focus on these critical issues. Another one of our priorities to which I am deeply committed is ensuring veterans have timely access to care. VA is taking steps to expand capacity at our facilities by focusing on staffing, space, and productivity. We're also increasing transparency and empowering veterans to make more informed decisions about their health care through our new access and quality tool, accesstocare.va.gov. This tool will instill a spirit of competition and encourage our medical facilities to proactively address access and quality issues, while empowering veterans to make choices according to what works best for them and their families. It also allows veterans to access the most transparent and easy-to-understand wait times across the VA and quality care measures across the healthcare industry. We are in the process of redesigning and modernizing VHA, and this budget supports those efforts. We recognize that we must address how community care is accessed and are committed to streamlining and improving it. A redesigned community care program will not only improve access for veterans, but will also transform how VA delivers care within our facilities. Community care access must be guided by principles based on clinical need and quality. VA will continue to partner with Congress and the other stakeholders to achieve our common goal of providing the best care we can for our veterans. Additionally, as you know, Secretary Shulkin announced that VA will start the process of adopting the same electronic health record as DoD to ensure continuity of care between the two departments. We will be incorporating the lessons learned through our pioneering work with VISTA as we move forward. We will also be creating an integrated EHR product that, while utilizing the same DoD platform, will require meaningful interface with other vendors to create a seamless system that serves the veterans in the best possible way. We believe that this product will serve as a model for the federal government and healthcare across the country. Finally, VA is committed to providing the highest quality of care which our veterans have earned and deserve. I appreciate the hard work and dedication of all of our stakeholders. We're all committed to making VA strong, and this budget does that. I look forward to continuing our partnership with this subcommittee and the entire Congress as we work together to continue to enhance the delivery of healthcare services to our nation's heroes. I know you share my personal commitment to make sure veterans get the very best of care. Mr. Chairman, members of the subcommittee, thank you again for this opportunity to testify. My colleague and I are here to answer any questions.
Well, thank you all very much. I'll now yield time for myself for questions. If I can start, Dr. Alay, in response, for the record, to our hiring hearing that was held in March of this year on the 22nd, we were told that, quote, there are currently 38,000 vacancies across VHA as of April 4, 2017. That's using data from VHA's web HR system. So when VA states that they have a certain number of vacancies, are those positions considered funded, and by that I mean appropriated funds that are available to fill those positions? Then are those funds, if they're not expended for the position, what happens with them? Does that money get rescinded or rolled over if not used, or is it repurposed within a particular budget line?
Thank you, Mr. Chairman, for the question. Our goal at the VA is to make sure that our veterans are getting the highest quality of care with the greatest amount of access. In this year's budget, we've budgeted about 7,000 additional FTEs. And if those FTEs are not filled, those dollars go back to providing care through the discretionary funding. So if our veterans have to go into the community, then those dollars go back in terms of ensuring that our veterans are getting care either inside the VA or outside of the VA.
So it goes back into caregiving specifically?
Yes.
Okay, thank you. Ms. Elam, Mr. Blake, Mr. Fuentes, Mr. Schuman, I understand your expressed opposition to the proposals in the budget request to enact changes, especially considering the rounding down the cost of living adjustment, COLA, to the nearest dollar, which of course at most would cost a veteran $12. I understand the principle of the whole thing. I get that. But at the same time, when I'm in my district and I'm talking to veterans and I ask them, and they're concerned about a certain program or a certain benefit that we've been talking about and they'd love to see enacted, I asked him, I said, would you be willing to round down and explain to them what that means? Every one of them has said yes. You know, they get in principle, he goes, but you know what? Veterans do that for veterans. So I'm a little confused on that one because it's not what I'm getting from individual veterans, but we always get it from the VSOs. And it's been done in the past. And, you know, some of those very veterans may benefit from the programs that at most will cost them $12 a year and at least 12 cents a year. That's a pretty good insurance policy for some of these types of benefits that they can receive. And so I'm feeling a little bit differently on that particular topic when I'm out talking to veterans. And I think that needs to be considered. We've heard a lot of things you're concerned about, and I appreciate you bringing those up. And how we go about funding and where monies go, that's a big discussion to have. But I really didn't hear many solutions, and I would really like to hear some viable solutions, some actual realistic solutions. Do you have how we can increase our fundings and find pay-fors or get offsets within? So I'd like to ask each one of you if you could comment quickly. I'm sure you discussed some of these. If you could share those with us, and we can go down and start with Ms. Elam.
I don't have any specific offsets that we could share. I think one of the things, based on our resolutions that we receive from our membership, really puts forth what we do legislatively, you know, talks about those specific issues of offsetting veterans, you know, one benefit to a veteran to, you know, pay for another program. And I think the concern is, you know, throughout our organization that we want to make sure that programs for service-disabled veterans are provided to them based on their military service, and we don't want to see an interference or trying to take away another benefit from another group of veterans.
Mr. Blake?
Mr. Chairman, I think your question sort of presupposes that in order to get to an increased level of funding, you would have to offset or find a pay for or something like that. I think the first thing we need to do is be honest with exactly how much it's going to cost to provide services. Because I think what we're missing here is in the early part of the process of budget development, a lot of these cuts and reductions and figuring out ways to tamp down how much we're going to request takes place within the confines of the Office of Management and Budget. And we never get to what does it actually take. I mean, the independent budget puts our recommendations forward, and our numbers are basically our belief of what it takes to provide care. I don't sympathize with the position that you're in that you have to figure out how to get to those numbers, but truthfully, I see that as a congressional problem, not our problem. Our problem is to tell you this is what we think it takes, and you have to deal with the political consequences of cutting or offsetting.
Yeah, and that's the reality.
Sure.
Okay? So that is the reality that we have. I mean, I can take it, since I've been here for 5 years, there are things where I know we're way overspending. And we have made some changes and working on some of those changes to bring costs down in other areas. And in particularly near and dear to my heart is to get more care to the patients and to our veterans in that regard. That should be the highest priority, especially as we're dealing with this today. But you can't ignore the reality, and so we're asking for you to help because, you know what, we're all in this together. And that's the point I'd like to make. So I'm asking, you know, you talk to veterans, you represent veterans that are going through the process, and they do a lot of talking, and it's a good thing they do. But they can come back with some measures and say, hey, you know what I observe, and maybe this is a way we can do it. We'll take those solutions. So I understand the complaints and the concerns, but solutions are helpful to us too. Mr. Fuentes.
And just to add to your mentioning, Mr. Chairman, you know, there is fraud, waste, and abuse in the system that must be eliminated. There are inefficiencies that must be corrected. I mean, there was just a release, I don't know the number exactly off the top of my head, about $26 million or so that the Secretary estimates to be able to eliminate in terms of his fraud, waste, and abuse task force. That's certainly the right approach, finding where to do that without hurting veterans. But frankly, you know, there are these improvements that are much needed. There's also nothing that says that it has to come from VA's budget, right? You have congressional rules that says that discretionary funding, mandatory funding needs to be offset, but that doesn't say that it has to come from this committee's jurisdiction. Now, I understand that the complications that come with that. But also, frankly, and it's been the VFW's position for quite some time, sequestration has a lot to do with why VA is not able to ask what they need, and why Congress isn't able to give them what they ask for. And we have said for quite some time, and hopefully you agree, we need to end this, setting arbitrary budget caps 10 years ago that are no longer, realistic.
Mr. Schumer.
Thank you, Mr. Chairman, for the question. You're absolutely right. We are absolutely in this together. The first thing I want to sort of point out here is that this country has made a promise to our veterans. And my colleagues here are right in that the money does not only have to come from the jurisdiction of this committee. During his campaign, the president made a promise that he was going to do the right thing for veterans, and we want to hold him to that. So we are standing by, willing to work with you and the White House to get the funds necessary to be able to take care of the veterans. To go back to your first point, and I'm sorry the time is over, our members, thousands of them, have to vote on our resolutions, millions, in order to get to where we are. And currently, our members are telling us that they are not in support of the COLA round down. So I would love to talk to the constituents that you have, and I'd love to make sure that our members are speaking with your office as well.
Yeah, I'm telling you that anecdotally. It's not a scientific study, and it's not a poll or anything like that, but I just asked the question. I appreciate the input. You might understand that it's difficult for any one committee to tell another committee's jurisdiction that they got to start giving up things. So I think you appreciate that.
We'll tell them for you, Mr. Chairman.
Ms. Brownlee, you're now recognized.
Thank you, Mr. Chairman. I think Mr. Blake pretty much laid it out in his testimony about where the challenges are here in terms of ensuring that we maintain and improve upon the programs we have promised to our veterans, and to be able to fund all of the programs. And with regards to some of these offsets, and we've Mr. Blake talked about the IU benefit as one example, and certainly the Secretary did in his testimony kind of back off of that as a way in which to help finance the choice program. But in your testimony, you still state that it is potentially still on the table as an offset. So I just wanted to clear that up, if we can clear that up today, or wondering if you have a different perspective.
Thank you, Congresswoman. As the Secretary has said, he will never do anything that puts our vulnerable veterans in a compromising position. And so he has committed to looking for another solution besides the IU at this point, and working with all of you on that.
And so is that something that you and your staff and the Secretary are all working on?
Yeah, we're all going to work together on it.
And do you have some sense of when you'll be able to share that with the committee, so we actually know kind of what we're really dealing with here? Because right now it just seems like we're going to figure it out. But I think this is the time when we're supposed to be really reviewing and digesting a budget so that we can respond to it. So it's difficult when we don't know.
Yeah, absolutely. We'll share it with you as soon as we're ready to share what our alternatives are.
Okay. And the same for the STOB ruling and the emergency care for non-service connected conditions. There's another sort of a blank there for how we're going to backfill a $1.5 billion without taking away items like the Choice Act. So I hear you're going to be working on it, and I think, I'm not sure when we'll, but it seems like we're going to have to convene another hearing similar to this one to get some of those responses back, Mr. Chairman. And, the transferring authority, too, is that still something that you believe is on the table to solve all or part of this problem? And if you could talk a little bit about that.
Yeah, thank you, Ranking Member. At this point, there are three options that we're exploring. The first option is something that we've already done, which is ensure that the choice funds continue until the end of this fiscal year. And to do that, what we've done is made sure that the accounts, the choice accounts are being used for the 30, 40-mile rule. And then for everything else that our veterans need outside of the VA, we're using the community care funds for that. That will take us, and we're managing that on a daily basis. That should take us, along with the community care funds, till the end of the fiscal year. However, it'll be at the expense of choice being trimmed down significantly. The other options are the transfer authority or infusing new funds into the mandatory funding stream in order to make sure choice continues at the same pace.
Okay, seems like we still have a lot of work cut out in order to figure out how we are going to, truly support these very, very important programs for veterans. On the IVF and adoption regulation that has gone through, I know that a rulemaking has been done for the IVF, and that program is, I think, underway as we speak, and that's good news. I still don't believe we have rule regulations for the adoption piece of that. So I was wondering how we are progressing on that.
So the IVF program, you're absolutely right. We have about 37 families who've already contacted us to be part of that program, and we're supportive of continuing the program into the next year. I'll get back to you on the adoption rules and where they are at this point, but definitely, that's part of supporting the whole women's health and overall programs.
Thank you very much. My time is up. I yield back.
Mr. Bilirakis, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. I thank the panel for their testimony today, and I thank our veterans for their service. Dr. Alay, I'm hearing an uptick in the complaints and concerns from community providers about VA's ability to comply with the prompt pay rules, particularly in light of the unexpected community care funding shortfall announced just last week. How does this budget support improvements to VA's claims process system, and what, if any, changes are needed in order for VA to fully comply with the prompt pay rule? And can you say anything to assure providers and encourage them to keep accepting VA patients? I will tell you that the providers I speak to, the physicians I speak to, want to see veterans. They feel like it's their duty and the obligation to see veterans in the community. But they're having a hard time getting paid. And you probably hear it. I think probably some of my colleagues do too. How can we solve this quickly? Because it's a great alternative to the, not that, I love the VA. There's no, the care is very good in most cases, but it is an alternative. And some of our veterans want to see private physicians. So please answer that question for me. I appreciate it.
Thank you, Congressman. I have to tell you, as a physician, it's just an honor to serve veterans, and there isn't a single physician who doesn't get touched by serving a veteran and taking care of a veteran. And I hear the same complaints as you do in terms of prompt payment, but also a bureaucratic process where there's a lot of administrative hassle. And so what we've done is we've simplified the process, at least for the time being, where we're requiring less of administrative back and forth and paperwork that they have to submit to streamline the process. We still have 20% of clean claims that are not paid within 30 days, and that's a problem. And so we're working with our TPAs. Our payment to the TPA is within 30 days. The TPAs then have to pay the provider. And so this is one of the areas of focus. The TPAs are willing to work with us, and we're looking at ensuring streamlining and automating of processes to ensure that our providers are getting paid. In the new RFP that's out, we're going to have much more rigorous and stringent rules and expectations on the prompt pay piece of it. Whatever we're hearing about issues are things that we're incorporating into our new RFP process that is going to be awarded the first quarter of the next fiscal year.
How are you utilizing the federally qualified community health centers? Is there a path there? I mean, would they be an alternative? I know you are utilizing them to a certain extent, but if you can elaborate on that, I'd appreciate it.
Yeah, they play a critical role in terms of access, especially in those critically access areas where we need to meet the needs of our veterans. So we are in discussions. We have an MOA with HRSA to ensure that the FQ8Cs are part of our network as we send our veterans out into the community.
Okay, next question. In your budget, what steps have you taken to ensure that complementary and alternative therapies, the services are available to our veterans? That's very important, and I know that the committee really cares about that. And I sponsored the Cover Act that passed last year. I want to know the status. The president is going to nominate two veterans, hopefully two veterans, on the committee soon. But you know, based on the budget, tell me how we're utilizing, and has it increased? You plan an increase so that veterans have access to complementary and alternative therapies that are obviously certified, but I know they work, and I think the veteran should have the choice to seek what type of therapy works for him or her. Can you give me an update on that, please?
Yes, sir. The complementary and integrative medicine is a core piece of how we provide whole health for our veterans. And what we have is 18 flagship sites that are going to be launched in October of this year, one in each VISN, that actually delivers the whole health model. And in that whole health model, you have 3 prongs. One is to make sure that our veterans are empowered and they come up with their own life plan. The second piece is to equip them, and equipment means to have access to complementary and integrative medicine. And the third piece is treating them. But complementary and integrative medicine is an important part of taking care of our veterans who are dealing with severe pain conditions and opioid addiction and some of the other very difficult to treat conditions.
Thank you. So if you could give me an update, follow up on this with regard to the Cover Act. I know that the secretary, I've talked to the secretary, and he has submitted names to the president. I want to see where we are on that. If you could get back to my office, I'd really appreciate it very much.
Yes, I will. Thank you.
Thank you. I yield back, Mr. Chairman.
Mr. Takano, you're now recognized. 5 minutes.
Thank you, Mr. Chairman. Mr. Blake, how important is it to VSOs or to the PVA? How high a priority is it that the 38,000 unfilled positions at the VHA get filled?
I would say it's critically important. Even from taking it down to the more narrowly focused SCI level, we've been working pretty closely with the VA to fill approximately 1,000 nurse staffing positions alone in the SCI system of care. It ranges somewhere between, I think, 900 and 1,100. But that's just a small snapshot, and that's just in the SCI service alone. If you take that out to a much wider net, I'm sure that it's critical to ensuring the VA can function at its maximum capacity.
Mr. Fuentes, how high a priority is it for you, for your organization?
In the past 3 years, we've surveyed our members on VA healthcare 6 times. And every single time we asked them, how would you improve the VA healthcare system? The number one answer is hire more doctors. So it's very important to our members. That's what they want to see.
Mr. Schuman?
Thank you, sir. It's absolutely critical. I mean, staffing bleeds into every single, even beyond VHA, every single element of the VA. So it's absolutely critical.
I can't see your last name. I'm sorry. My eyes are Ms. Elam. Ms. Elam, I'm sorry. Go ahead.
Thank you. Yes, absolutely critical for DAV members as well. They're high users of the VA healthcare system, and having access to those providers, plays into having timely access to care.
So, Dr. Lay, did I hear you correctly answer the chairman that that all of the 38,000 positions that are unfilled are funded?
So, Congressman, we have a steady state of attrition and hiring, and that steady state for an organization.
I don't have much time, but can you just
Okay,
answer
sorry.
the question, are they funded?
there are 7,000 positions that are funded.
7,000 out of the 38, so not all of the 38,000 are funded?
There's a 30,000 steady state of positions that come in and go at any given time. So our steady state is 30,000.
I'm confused by your answer because I'm hearing 38, the chairman himself used the figure 38,000 unfilled positions, and you answered affirmatively that they were funded. Is that true?
Yes. We have funded for 37,000 positions, 30 being the steady state and 7,000.
Okay, so 37,000 are funded.
Yes.
Okay, so out of the 30, so 37. That's quite a lot of money that's not being spent. You said that money does get spent though. It gets spent on community care. Is that what I hear you say?
If we can't hire, then it still goes into making sure that our veterans are receiving care.
How big of a commitment is it how high a priority is it for the VA to fill those positions?
This is a very big priority, one of our top priorities for the VA.
It seems to be a persistent issue, though. Every year we see these positions unfilled. I kind of see that if you are trying to fill up community care funding, that there is this perverse incentive for the VA to not fill those positions and use the savings to fund community care. Is all that money being spent on community care, the unspent money?
No, the money is being spent to hire our staff, our employees, and if all the money is not spent, it goes into direct patient care services.
Well, has all that money been spent? Does all that money get spent usually?
Yeah, I'll have Mark.
I realize it gets spent on patient care, but it gets spent through, looks like, other programs,
Sir, I
community
think,
care
I
programs.
think what Dr. Legg was trying to explain, typically we have a large number of vacancies that are open with the turnover that we experience. We have more than 300,000 employees across VA. No position gets advertised unless the VA Medical Center believes they have funds to support it. We have 7,025 FTE. That's a full year, full salary, full-time equivalent position funded in this budget for growth above that steady turnover. So when you're looking at some number above 30,000 vacancies, remember a lot of that is turnover. It doesn't mean that there's extra money sitting anywhere that would be used otherwise. But we've talked about the fact that the creation of the medical community care account has eliminated the opportunity at the medical center level to move money from in-house care inside the VA Medical Center to community care and back when those positions are vacant. If you're missing a surgeon for some period of time, you'll have to send that care out in order to continue to provide care to veterans. If you're able to hire that surgeon back, you'd like to be able to bring those monies back from community care and put it into our direct care system. So that's what she's trying to describe.
All right, I feel like we need to spend more, my time is out, but I'd like to understand more about how this works because I'm very frustrated, and I think the VSO community is very frustrated that we have all these positions vacant. I'm trying to understand there's more than just a money issue. I mean, there's definitely barriers, but I don't want to be, I want to be courteous to the committee.
I think just the one thing that we've lost as a result of this is our 3 Rs. So the recruitment, retention, relocation incentives to make us competitive with the community and the marketplace, we've lost that. And that's made it a little more challenging to bring in employees into the system.
Well, thank you, Dr. Lay.
Ms. Radewagen, you're now recognized for 5 minutes.
Thank you, Chairman Wenstrup and Ranking Member Brownlee for holding this hearing today. And thank you, Undersecretary Alive and the VSO representatives on the panel for taking the time to testify. We appreciate you being here. As you know, this budget request calls for increases to veteran services across the board. And in that regard, I'd like to praise the department for their commitment to caring for our nation's heroes. I hope to continue to work with the VA to bring further improvements to veterans' health care and accessibility to services, especially for veterans out in rural and remote areas like my own home district of American Samoa. However, as is usually the case, there's still much work to be done. For example, I'd like the VA to work in conjunction with DOT and other related departments to make improvements to LBJ Hospital, the only hospital in the territory, which currently cannot treat our veterans due to lack of adequate resources. As it stands, our veterans must be flown to Hawaii and put up in a hotel for several days on the taxpayers' dime to receive even the most basic care. Last year alone, $3.2 million was spent on that exercise alone. That's a lot of money. This budget is a good first step, I think, and I look forward to more improvements to veteran services to come, especially for our veterans in the remote U.S. territories. My question for you, Dr. Alai, the budget cites that the Supportive Services for Veteran Families program has a presence in all 50 states, including Puerto Rico, the District of Columbia, Guam, and the Virgin Islands, but does not include American Samoa. Does this mean that SSVF services are unavailable in my territory? And to follow up, how do the needs of homeless veterans and their families vary by geographic region? Specifically, how does the VA work to address the needs of homeless veterans in rural communities that may be particularly isolated from services?
Thank you, Congresswoman. We are committed to serving veterans regardless of where they are. And so if this is a specific issue in the Samoa Islands, we really do want to look into it further. Since we contacted your office, we're already starting to work with the local hospital there, which is a government hospital. We're looking for ways to collaborate with them because we're two governmental agencies. And we're going to continue making sure that we synergize our efforts. And if there are still gaps in services, then we will work together on those.
Thank you, Mr. Chairman. I yield back.
Thank you. Ms. Custer, you're now recognized.
Thank you, Mr. Chairman, and thank you to the committee, to the panel for being with us today. We appreciate it. I wanted to ask about the issue about consolidated community care network that was outlined in the VA report. This was late 2015, and get back to the question that Mr. Billericus had started about the federally qualified health centers. My question is, has the VA developed this plan any further to integrate these facilities, especially with regard to this moving to an off-the-shelf health record? And is that a barrier, or will that be helpful to integrate the federally qualified health centers?
Thank you, Congresswoman. Our goal is that veterans get seamless care, regardless of where they're getting care. Going down the path of adopting the DoD EHR platform is only our first step. And it is very clear, as we're moving down this path, that the interoperability and the seamlessness of connectivity has to happen with all of our community providers like FQHCs and our private physicians at the same time.
Okay, and then continuing that, that train of thought about the adequate funding, whether there's sufficient funding to successfully implement the evolution of the electronic health record. How much money will the VA require in the FY18 budget to implement the evolution? Because I recall Mr. Shulkin saying the monies are not included in this budget request.
Yes, and that's an important question to ask because this is a huge implementation that's going to take years. But the most important thing, and having learned from the DoD experience, the first 2 years is really about change management, going through the specifications and making sure the standards align. And so for the first 2 years, we have enough in the budget to be able to support the field assessments, going through the specifications and doing change management. It's going to be in year 3 that we're going to be asking for additional and significantly additional funding to be able to implement it.
So we shouldn't expect a supplemental budget request for FY18?
No.
You're saying it'd be 2020?
It won't be in 18.
Okay, okay. The other reason that I'm concerned about the requested funding for the IT system, it seems too low to accommodate simultaneous transformations of the electronic health record as well as financial management system, antiquated benefits management system, and one that I continue to try to pursue is a more efficient and effective scheduling system. So regarding the scheduling, will VA continue to pursue the MASS scheduling pilot? And if not, what does the VA plan to do to improve its scheduling software?
Again, a very important point. One of the things that has been responsible for some of our access issues, including discrepancies and wait times, is our complex scheduling system. So we're rolling out the VSC, which is an interim solution, while we're still doing the MASS pilot, because all we're doing right now is contractual negotiations with the DoD product. So in the meantime, we still are moving ahead with rolling out VSC, which is going to be our interim bridge, and then also seeing what the MASS pilot demonstrates, because we'll have lots of learnings just doing that pilot, and we still want to have options of the best software modules to be able to deliver the best care for our veterans.
Well, many of the members of this committee were on the committee when the Phoenix scandal was all over the news, and we certainly want you to resolve the scheduling issues, use the resources and the personnel that we have efficiently, and not end up back here deja vu all over again. So I'll wish you well with that. One last very quick question. I just have 30 seconds. I'm concerned that the VA is not requesting adequate funding for medical research programs, and in particular, the research around pain management and use of opioids to bring down the use of opioids in the system so that we don't continue to create more and more and more people with substance use disorder, veterans that are addicted to opioids, heroin, now fentanyl. Is there anything that you could say to comment on that?
A third of our research funds do go into mental health and substance abuse, including PTSD, suicide, depression. We're going to continue down that route. We will have to look for additional partnerships and other sources of funding because we are a leader in research. We come up with breakthrough research. The rest of the country follows us. And so we're going to continue that momentum, in our current environment.
Thank you very much. I yield back.
Dr. Dunn, you're now recognized.
Thank you very much, Mr. Chairman. Dr. Alay, what will be the impact on veterans care if Congress does not act to replenish the Choice Fund, and when will those consequences be felt?
This is a serious concern, and we have a plan that we've implemented right now because under no situation can our veterans ever not have access to high-quality care. So what we're doing right now is managing the two accounts, the Choice account and the Community Care account, and making sure that both those accounts last till the end of this fiscal year. There will be unintended consequences if we continue down this path because the Choice accounts will start to be used very judiciously. And so I do know that the TPAs have put in a lot in terms of...
Let me interrupt you if you can right there. The TPAs, you made mention of those earlier, and it sounded like you were saying they were the problem paying on time. I was surprised you farmed out the third party, the administration of the Choice funds to some external consultant.
So this was a program that was stood up in 3 months. And if you look at any other managed care organization, it takes decades to stand up a program like this. And so we're still dealing with bumps along the way, and this is one of the things that we're going to have to work on.
Are there other less mission-critical areas that you could tap the money from in the VA for the Choice program?
We can transfer funds from the discretionary accounts into the mandatory accounts. So we can
maybe
transfer funds
from the mandatory, other places the mandatory account. Let me change tax here just for a minute. The vision statement attached to the budget said that the VA will focus on its foundational services, the ones that they can excel in. What are those foundational services?
So right now, we know the foundational services are primary care, mental health, SCI, polytrauma, prosthetics, mental health. All those are our foundational services. But depending on the marketplace, we will add additional foundation services. For example, high-volume medical specialties, some surgical specialties.
So let me take a dive into surgical specialties really quickly. Just one that's near and dear to my heart, as I was a former transplant surgeon. It's understanding that the veterans often need transplant care, have to travel hundreds or thousands of miles to receive their transplant care, and then it may not even be done at the VA Transplant Center. It might be in an academic affiliate. Why is the VA hesitant to let veterans pursue transplants in the transplant centers, certified transplant centers, near their home, where we know the transplants are more successful and they're much more likely to get the transplant.
Yeah, you're absolutely right, Congressman Dunn. This is an area that we have to redesign and change because as long as the transplant centers that have the best possible outcome after the surgery and have the team that can best manage it, we should be opening up the networks, and we're already doing that in certain cases.
So I can interpret that as that policy is going to go away. We're now going to be able to use the transplant. My veterans in Florida are going to be able to use the transplant centers in Florida, and they will not have to go to Pittsburgh or...
We're doing a market analysis, and we're going to finish that market analysis in a year, and after that we'll show you. But in the meantime, case by case, we're making exceptions and making sure that our veterans are going to the best possible places.
All right, in the little time left to us, let's take a look at the $226 million line item for modernization and interoperability of the VISTA health record system, which I gather we're abandoning. Right, we're walking away from that, going on to the DoD system. $226 million for a system we're leaving? Help me.
This includes the change management that we're going to be doing as we're rolling out the new EMR.
You say that's the cost of adoption up front?
Yes.
$226 million.
And also maintaining some of our legacy VISTA systems along the way.
Thank you. I yield back, Mr. Chairman.
Mr. Higgins, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Alay, thank you for your service. I'd like to follow up on what my colleague asked. Why does it take a year to figure out what everyone in this room knows is already an accurate conclusion? A veteran should be able to get a transplant in his own home state. This is just common sense. This is the type of thing that we're tired of. This is the kind of thing that veterans from sea to shining sea come to a veteran like me as a representative, and they say, Cap, why don't they get it in D.C.? So please tell us, why does it take a year to figure out what this distinguished surgeon has come to the conclusion of already, and I imagine the other doctors on this subcommittee? Why a year?
Again, a very valid concern. As you know, the VA delivers some of the best outcomes in quality care, and in order to ensure that our veterans are getting the highest quality of care, we're going to be doing an analysis of all the services that should be provided inside the VA versus...
And what does that cost? Because we've just arrived at that conclusion, it costs nothing.
And Congressman, it's not just for transplant services that we're looking at hundreds of different types of specialties and services. And at the same time, looking at veteran demand, we're looking at reliance, we're looking at what the highest performing providers are in the network. Depending on where our veterans get care is directly correlated with the outcomes for our veterans. And we want to make sure our veterans are getting the best possible care.
Thank you for your patient response, ma'am. Please understand my passion is strictly reflective of my love.
We're on the same side.
For our veterans. All of us, in one way or another, continue to serve our country. I thank the veteran service organizations present, been very helpful to my office in particular. Matthew Schuman, the director, has been very interactive with my office and help us as we move forward. Talking about the budget, as soldiers, sailors, airmen, and Marines, we recognize sacrifice for our country. And please let us note that the VA and the VHA has received a significant increase in funding despite the fact that our nation faces a $20 trillion debt. That's the people's treasure that we must protect. And despite that we exist in an era where we face such a danger to the future of our country, the VA and VHA has received a significant increase in budget, which I believe is reflective of the spirit of this subcommittee and the VA committee as a whole, and of our president and of this body from both sides of the aisle. So my question, ma'am, if I may jump into veterans' homelessness. The VA and many local and state governments have made tremendous strides in reducing the rate of veteran homelessness. However, nearly 40,000 veterans and their families still face homelessness. The 2018 budget requests $1.7 billion to assist homeless veterans and prevent at-risk veterans from becoming homeless, in part by building a capacity of available residential, rehabilitative, transition, and permanent housing supply. And the VA has a program called the VA Enhanced Use Lease Program. Occurs to me to be a very wise investment of the people's treasure. Can you please provide information to this subcommittee regarding appropriate properties that the VA could utilize for job training, medical services, transitional housing for our homeless veterans and their families, please?
Yes, we will.
I would like those properties identified. If you could provide that to the subcommittee, I would appreciate it. In my remaining 40 seconds regarding caregivers, under the Program for Comprehensive Assistance for Family Caregivers, 24,555 primary family caregivers were approved in 2016, 33,345 in 2017, and expected 37,100 caregivers for 2018. This is significantly higher numbers than were expected when the program was initially established. Has the VA begun working to ensure that the Caregivers Program can continue to provide services and stipends to the veterans and caregivers most in need? And can you lay out how the program has and will change to ensure its longevity? It's a crucial program for our veterans.
Yes, I mean, the caregiver program is a very important fabric of how we keep our veterans at home, independent and autonomous. So we support the program. We're working on redesigning the program so that we can also offer it to the pre-9/11, the most vulnerable veterans who need it. But in the meantime, we have a whole compendium of services that we can use to help support our veterans so that they stay at home. Our home-based primary care and respite program, lots of different other entities are.
I applaud your answer, ma'am, and I thank you particularly for mentioning pre-9/11 veterans. Mr. Chairman, I apologize for going over time. I yield back.
Mr. Chairman, Dr. Rowe, you're now recognized.
Thank you, Mr. Chairman. And just an opening round, I know one of the things we hear every year is about how the VA is, the VSOs are worried about being privatized. And while the subcommittee was asking questions, I looked up some data. In 2009, the entire VA budget was $93.7 billion. There were about 240,000 employees, I think, at that time. This budget request is for $186 billion. That's for FY18. That's in 9 years. That's a doubling in 9 years of the VA budget. And the VA currently has 364,000 employees. It's over 100,000 more people working than 8 years ago or when I came to the U.S. Congress. So I don't see how in the world anybody can make an argument that it's being privatized. I think what the VA is trying to do is provide the very best care it can for veterans. And if they can't provide it in-house, they wanted a way to provide it outside, just as has been mentioned on the transplants and other things. And I applaud them for that. And I'm sorry that Mr. Higgins just left, but I was in Los Angeles a couple of months ago. And they're using property there. 10% of the homeless veterans in America are in Los Angeles County. And they're using a 386-7-acre campus, and many buildings that have been abandoned are not used. They're refurbishing those buildings for homeless veterans and creating a village there, and with all the other support services, with a HUD-VASH and so forth. It's a tremendous program. I was in Fayetteville, Arkansas, Monday with the secretary. And they've taken a building on the campus and have rehabbed it for inpatient mental health treatment up to 90 days for alcohol and drug abuse. And we know that Medicare now stops paying after 15 days. You can't do the care in 15 days for drug abuse. And VAs recognize that. And so they need a shout out for those programs that they are doing. There are some really good ones around the country. I think we hear all the bad. We don't hear a lot of times the good. We have a tremendous a problem. In the Budget Control Act, Mr. Fuentes mentioned this, with budget caps. He's correct. We've kept our discretionary part of the U.S. budget has been almost the same. which means that we've taken away from education and Department of Defense and other things to provide services for the VA. And I get a little frustrated sometimes because I know we've done that. And I mean, have other requests that come on from educators, from people in other parts that are very needy parts of our society, too. So I think this committee has done what it can do, and certainly listening to everybody and trying to provide every benefit we can for the VA. A question that Mr. Takano was talking about that I want to get a little bit clearer myself was that when you budget money for, let's say, a physician, and it takes the VA, that money is appropriated, and then it takes months because of the VA's convoluted way they fill that position. What happens to that money if you hired that physician on day one, that nurse, it doesn't matter, that healthcare provider, that money's been there for 6 months. What happens to that money and where is it? Because it's not spent because the position isn't filled. I think that was your question, wasn't it? Yeah. So is it then are you saying that if a surgeon, I think I heard Mr. Yao say, and I don't have to add, Mr. Yao can answer if he wants to, but if a veteran like myself would come in and need a hernia fixed and there's no surgeon there, would you use that surgeon's salary that you would have been paying to pay for my community care? I think that's what he was asking. Or where is the money? Is it still there?
Yes, sir. Remember, what we have in the budget is an FTE, a full-time equivalent salary for 7,000 FTE.
That's a person.
Over the course of the year.
An FTE is a human being that if you hired them that day would go to work and get a salary.
It's a full year salary for a human being, yes, sir. And when we're hiring new people, those 7,000 FTE may represent 20,000 new hires, depending on when they were hired during the course of the year. So it's new money that goes towards hiring. In the event that you can't hire someone, say in a remote location, that's what we're talking about. We used to have the ability, when it was all within the medical services account, to move those funds back and forth between purchasing the care if we had a vacancy, or if we were able to bring somebody in, bring it back to provide in-house care. It still goes to care for veterans regardless.
So it is, in other words, it's not spent on salary, but it would be spent on paying a physician outside. That's what I'm trying to get to. Is that correct?
It may well be, or it may be paid. We do something called fee-basis physicians, where we hire a contract physician and bring them in-house to provide care.
Sure, I mean, but it's paid for care. That money is not just sitting in an account somewhere accumulating.
No, sir, it's used.
Okay,
it's all going to care for veterans.
I think that wasn't clear to me either. I agree with that. I see my time has expired, Mr. Chairman.
Thank you, Mr. Chairman. I appreciate that. I actually have 5 minutes myself now that I've moved into the chair. Dr. Alay, let me ask you this. In your written testimony, it says, in addition to increasing the number of veterans accessing care through the CHOICE program, VA is working to increase the number of community providers available through the program. And I can tell you, as a result of the way some of these providers are being paid, I just passed a letter to Chairman Rowe earlier, a provider in Jacksonville, Florida, who is no longer going to see veterans because they are hundreds of thousands of dollars behind in payment. And there is a hospital who has the letter on the way that is also going to no longer see veterans. And so I'm very concerned because one of the purposes for the CHOICE program when Congress enacted that was because veterans were not receiving access to care that they needed and deserved. And so we now see you're trying to add facilities, and we're losing facilities as well. So I'm concerned about that. Can you tell me how the VA plans to address this problem?
Congressman, this is an important problem, and one of the reasons of dissatisfaction in our community providers. And we are working, again, very hard with the TPAs, but at the same time, all the learnings that we've had from the input that you've been giving us and we've been working together on with our partners here around the table, we're incorporating that into our new RFP process where we'll be able to award new TPA agreements where there is more accountability and they're held responsible for prompt payments and making sure that our providers, the providers are satisfied as part of being part of this network.
Okay, you know, another concern that I have when I hear that it's going to take a year to assess transplant facilities that are already certified, and VA is now going to do some, I guess this is like an internal certification that you do of your own? Is that what's going on here?
No, this is not a certification process. What we're doing is, as we're looking at how we identify a high-performing network and also identify what services we develop inside the VA based on region and marketplace, we're doing a detailed market analysis.
If I could interrupt, though, these facilities are already certified. They're out there. Folks are using them every day. And so I'm concerned that that's going to take a year. I'm also concerned, I heard you mention that it's going to take 2 years to do an assessment and alignment to figure out the EHR and the integration with DOD. Now, Secretary Shulkin sat at that table and said, we're not in the IT business anymore. We're going to go out and we're going to find product that meets our need, and now I hear you saying that we're going back to the old 2-year process of studying something, looking at something, figuring out what the elements need to be to create this integration. Tell me what this program needs to look like that is so different that it's going to take 2 years to get alignment.
Congressman, any big project like an EMR implementation requires a lot of change management. We have providers, we have nurses, we have clinical teams that have been used to using a certain electronic health record. It's sort of part of the core of how we deliver care today. In order to make sure that the off-the-shelf product is customized to all the different elements of care that we've incorporated into the VA, because the VA does such amazing things with team-based care and PAC teams, we're going to have to customize a lot of those standards and specifications. That's what's going to take time. We're going to have the frontline physicians, nurses, all involved with this. There are different, like there's an OR piece, there's a behavioral health piece. All those things are going to happen because it's going to be a bottom-up approach. EMR implementation cannot be a top-down approach. It has to be a bottoms-up approach.
Seems like you just go pick it off the shelf. You know, I mean, that's what Secretary Shulkin was talking about. So my time is up. Thank you very much.
Thank you very much, Mr. Chairman. And I appreciate very much you allowing me to join you this afternoon. Dr. Ali, or Mr. Young, what efforts are being made to recruit and retain? Well, let me go back. Let me try to understand. I think Mr. Takano brought it up. You have 7,000 vacancies, or was that 37,000 vacancies?
We have the budget to support a 7,000 increase in FTEs.
FTEs, and that's medical professionals, or that include clerical?
It could be everything. It's
everything. Okay. And you already have, right now you have over 180,000 employees.
Over 300,000.
Okay, right, thank you. So, okay, so what? And let me go parochial here. What efforts are being made to recruit and retain healthcare professionals for remote and underserved areas, and have they been successful? Let me say this. I understand that staff from the Pacific Island Healthcare System, that a licensed clinical social worker position was approved for my district, the Northern Marianas. What is the status of that recruitment?
I'm sorry, for your social worker?
Yes.
I'll have to get back to you on that.
Okay. And if you do have that information, we have a way of getting out federal job announcements on a weekly basis. And if you would share with us, and we could help you promote, provide that information in our newsletter. It goes out to,
Yes, absolutely. In fact, there are two programs that.
thousands of people. Yeah,
Yes.
because right now you only have a clerk who handles appointments and a fee or contracted physician. Thank you. You also mentioned earlier that the VA is trying to manage choice so that funds last through the end of the fiscal year. Could you explain how the VA will do that? When I thought you mentioned prioritizing those veterans, I thought you also mentioned prioritizing those veterans living 40 miles from the VA facilities. Is that correct?
Correct.
So those veterans who live 40 miles away from a facility will be prioritized? Or if they travel by sea or by air?
Yeah, they will still be prioritized as part of the choice program, and then we still have community care funds for the other veterans.
Okay, right. So, Mr. Yao, is that? What is the FTE formula for determining the number of healthcare professionals needed in remote and underserved areas, particularly, again, areas like the Northern Mariana Islands?
Yes, sir. I don't believe that VA currently has any sort of a standardized staffing methodology to determine that. It's been determined at a local level based on resource availability. I believe we're in the process of looking at several different types of models to use, one of which we're looking at is the DoD model for their fixed facility hospitals to see if we might be able to standardize staffing across the VA, but it's been very much a decentralized process.
But neither VA or DoD has a facility in the Northern Mariana, so how do you use that model how do you use it to get information on the number of people you need?
Yes, sir. It would be driven by the patient demand that you'd have in that area and the scale of the size of the local facility. But like I say, we're very much in the beginning stages of that process.
Yeah, my next question is, I moved, I guess. Thank you very much. Thank you. I yield back my time.
Gentleman yields back. Thank you, Mr. Sablon. I believe Chairman Rowe has a follow-up question.
I do, just very briefly, and thank you, Mr. Chairman, for yielding. A follow-up from what Dr. Dunn was talking about just a minute ago. If Congress does not replenish the choice fund, will wait times lengthen like they were before Phoenix?
Yes.
Okay, that's one thing I wanted to know. Will veterans be able to seek appointments in the community like they have before if the choice is not replenished?
No.
And will the TPAs have to let staff across the country go if it's not replenished?
Yes.
They will. Okay. Now, those are the three things I would have liked to have had placed on the record, and I yield back.
Thank you, Mr. Chairman. I believe Mr. Takano has a follow-up as well. Oh, I'm sorry, Ms. Brownlee.
No, that's fine. Go ahead.
Okay.
So I just want to get clear about Dr. Lay, or is it Dr. Young, who's next door? Mr. Yao. Mr. Yao. Okay, I just can't read the names. My eyes can't see. These are reading glasses. These are not binoculars. So let me get this straight. So you have 7,000 funded FTEs for personnel in VHA. But how many vacancies are there?
I've heard the Secretary use numbers between 35 and 45,000, but I think our personnel staff are trying to go back and verify those. We have a number that are open for any period of time for repeated vacancies for things like nurses and so forth. So I believe they're trying to go through right now and scrub that and come back with a better estimate. But like I say, typically we have about 10% of our total workforce that will turn over within a year, so that would be about 30,000 at any given time that we'd be recruiting.
So there's a 10% turnover, but there's also positions that are unfilled in addition, right?
Yes, sir.
So it's more than, so the total workforce represents a shortfall in what is needed. And so I'm trying to get a sense of that. Mr. Fuentes, You mentioned earlier, I want you to kind of explain more what you meant about that you feel that the VA's budget was shorted or constrained by sequester. Can you elaborate just a little further on that?
Yes. Thank you, Congressman. So sequestration occurred because, this was a super committee that was created in 2010 to essentially reduce the budget over 10 years for a certain amount of, I forgot the exact billions amount of money. They failed, so then it was arbitrary, every year, 10% cut of the budget. There were negotiations past 4 years. In 18, the budget for fiscal year 18 revolts back to those budget caps that were set 7 years ago. So what really happens is when you have, the overall cap, then you have to decide how you're going to split that money. And really, because of that, VA is impacted in how much they can request because OMB tells them you need this much money, but this is only how much you can get. And then it also limits Congress's ability to provide, to fully fund what VA has requested because of the needs of other departments, other committees, and other programs.
Well, thank you. And I just have one
Would
more.
the gentleman yield?
I do want to ask one more question, but if I can just ask the last question, but I will yield.
Just very briefly, just to put that in context, like I said a moment ago, I was here for the BCA. We had a number in the discretionary part of the budget that we funded. We've taken money away from other departments and almost doubled. Matter of fact, over doubled the VA's budget, just for clarification. I yield back.
Thank you, Mr. Chairman. If I could, I just want to ask a question on homelessness. It was mentioned before. In 2015, the Supportive Services for Veterans Families, SSVF programs received nationwide surge in funding. That surge consisted of about $300 million to 56 communities, including my own, over 3 years. Those funds dry up at the end of this fiscal year. In order to maintain the same levels of services and prevent the expiration of these surge grants, the SSVF program would need up to $80 million more in fiscal year 2018 than the department requested. Now, many communities that receive that money say it is still necessary to end veterans' homelessness in their areas, and some communities have reached the goal of ending veterans' homelessness with that money, say that it is also necessary to rapidly rehouse newly homeless veterans in their areas. Now, these areas will need funding for the SSVF program. Now, please explain why the department's budget did not reflect the cost of maintaining these surge grants.
I can tell you that homelessness is one of our most important priorities. We've made huge strides in fighting homelessness. We have a 4% increase in our homelessness budget for FY18, and we will continue to make sure that we're working on appropriate case management programs, appropriate housing programs, and also the grant programs that all of your communities get in terms of the ability to fight it. About 50% of our funding actually goes to those grant programs in each of your communities.
Well, I'm going to take this for the follow-up for the record, and written, but as I understand it, HUD has cut from $60 million to $7 million funding for the HUD portion. I'd like to be able to, if the VA considered that as they were making their requests, but I'll take that for the record later.
Okay, thank you.
Thank you. Gentleman's time has expired. Ranking Member Ms. Brownlee.
Thank you, Mr. Chairman. Since we've been talking so much about the vacancies within the VA, which is a very, very important topic, I just wanted to ask the question because I know that we have had many hearings about HR services and the vacancies that needed to be filled within HR. Can you tell me within HR, across the board in the VA, how many vacancies there are within human resources? These are the people that actually hire the people.
Ranking Member, this is one of the weak links for us right now, and we don't have enough HR staff to support the hiring process. And we're looking at different ways of improving that hiring process. One of those programs that I know I was talking to Chairman Winstrup about is the War Tech program, where service members in the last 6 months before separation can be trained while they're still in their military facilities and be brought into the VA system. And so that's one of the things that we're going to be focusing on as we're trying to hire HR staff, scheduling staff, and logistics staff. Those are going to be our 3 focus areas.
Okay, it's hard for me to imagine that an HR staff, I mean, I can understand doctors, I can understand nurses, I can understand a lot of reasons and barriers for filling those pipelines and hiring those people. It's hard for me to understand that we can't fill positions in human resources. It's just hard for me to understand, and I'd like to know a little bit more about that, and I would like to know with accuracy what are the vacancies within human resources. My colleague here is also saying that I know we had a hiring freeze. I don't know if that freeze is still on or off. Pardon me?
Does it affect HR in particular?
There's a freeze on human resources?
No, there's no freeze on any of the field positions at all. The field can hire, including HR, IT staff, and all the staff.
Okay. And then the last thing that I just wanted to get back to for a minute, which we talked a little bit about in my office yesterday, is Cerner and the electronic health record. So I was wondering if you could, give the committee a basic timeline. I think Mr. Rutherford is surprised that he's hearing that it's going to take kind of 2 years to kind of gear up with the Cerner system to have compatibility with the DoD. And, you've given all the reasons why that is. And I think I understand it a little bit more because we had a deeper conversation in my office yesterday. But as I said to you in my office, I'm surprised because I was as surprised like you were. But if you could provide us, or if you could tell us right now, which would be great, what you believe the timeline is. I know you said in the office it's going to take 6 or 8 months to negotiate a contract, and then it's going to be kind of a 2-year period to get up and going, and that's the interoperability between the VA and the DoD. And then we've got to figure out, the Cerner system doesn't come with automatic interoperability with community partners. And so that all has to be figured out too. So I started to think yesterday, well, this is going to be, a pretty extensive timeline before we actually get to the place that we all want to be. So do you have a specific timeline that you can share with us so that we can monitor it?
Yeah, absolutely. And what we're committed to do is once we've developed the high-level implementation plan, we'll share it with you. The committee's been amazing when it comes to every step of the way as we've developed new programs, including the new CARE program. So we will be sharing this with you along the way. But yes, 3 to 6 months for negotiation and executing on the contract, and then preparing the field for it. And we're talking. This is what happens in EMR implementation at this scale. This is not different in the VA. The DoD is going through this, and this is one of the largest implementations ever for any healthcare system. And you want to do it right. It's patient safety. You don't want to lose data. You want to make sure all the users know exactly what to do and have all the key elements of care that are going to ensure that the patient's getting the best possible care. So this is not something that you just do with the turn of a switch. This is something that has to be done very carefully. And again, as I said, it has to be a grassroots effort. It's not something that we just say this is what the product is and you just go ahead and implement it. But I can understand how you're feeling about this. It's going to be a multi-year, 5 to 10 year project at this point.
Well, what I'm interested in, and I hear it and I'm understanding it much better, but what I would really like is a very specific timeline
Yes.
in terms of what the implementation looks like.
Yeah, and we will share it with you. The secretary is so committed to making sure that we're walking, with you every step of the way. So we will be transparent.
Okay, and then I understand that there's a, the VA would have to issue a solicitation to Cerner. I'm not quite sure I fully understand what all of this means, but if you have to offer a solicitation in the negotiations of the contract, does that make sense to you at all? That, my understanding is a solicitation to support the fact that you're awarding a sole source contract. But I guess my question is, have you looked into that? And if you have, are you going to need any kind of legislation to move forward with that? I
Yeah,
guess.
my understanding is no, but if we do, we'll get back to you on that.
Okay, very good. Thank you. I yield back.
And he yields back. Before we close, I would like to have a follow-up myself with Mr. Yao. I presume that hospitals run a lot like other facilities that require fixed post positions. I want to go back to this vacancy situation a moment. Fixed post positions often require overtime. Do you have an overtime budget at VA?
We'll have to get that for you. I don't have that with me, but we do track it.
Okay, and if you could at the same time, what I'd like to know is, number one, what is the overtime budget? And number two, how much of that budget overtime is directly related to the vacancies that you're being forced to carry? Can you get that for me as well?
I'm not as confident of the second half of your question to be able to differentiate the vacancies versus the overtime compared to anything else, but we'll give it our best effort.
Okay. But Dr. Arle, you don't track it that way?
Like I said, we're going to go back and look into it.
Okay. All right. Thank you very much. Thank all of you once again. I really appreciate your testimony here today. If there are no further questions, the panel is now excused. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extemporaneous material. Without objection, so ordered. This hearing is now adjourned.
Nicely done.